Welcome everybody to yet another live. Oh, my microphone's going all over the place. I hope you're all doing well. My name is Christopher Balkerin, and I'm here to chat with you about an issue that I think so many of us want to know about more and are actually surprised at what our governments are doing when it comes to medical assistance in dying. It's a very grim topic. Nobody really wants to talk about this in a very open way. And I think that is what sometimes leads to the challenge. It's like when we don't talk about things, the government really does go about doing things without us knowing and without proper public consultation. So in this video, what I'm going to do is we're going to chat about medical assistance in dying. Because here in Ontario, we actually have the MAiD Death Review Committee. It's a MDRC. It's out of the province of Ontario. And they just released their latest report. Now, the Death Review Committee, as I understand it, are made up of citizens. They're not made up of specialists, to my knowledge. And they look at those approved for medical assistance in dying, and they look at some of the trends, etc. So again, I want to do this justice. So I want us to make sure that we understand precisely what medical assistance in dying is. And that's when people willingly choose to end their life due to either a diagnosis or what's going to happen. There's two tracks, one where death is certain and one where death is not certain. If you can believe that in Canada, that's true. There's two tracks for medical assistance in dying, one where death is certain and one where death is not. And this is what leads a lot of people around the world to scratch their heads a little bit when it comes to Canada and how we've applied this. Now, I will say the overwhelming majority of medical assistance in dying patients choose track one where death is certain. So you have a terminal illness. It's only a very small fraction where death is not certain that are qualified for track two. So I just want to put that out there because often that gets conflated. But despite this, track two has grown in numbers over the past few years. And again, I want to put this into perspective as well. Canada has some of the world's highest numbers on a per capita basis for medical assistance in dying. Some of the highest numbers in the world. We outpace some European countries that have had MAiD for a longer period of time. And so this is something that we should all be a bit concerned with. MAiD, if it were categorized, it's not. But if it were categorized as a cause of death, it would be, I believe, in the top 5 or 6 causes of death here in Canada. So it's something that, again, we should all just really be aware of, because I think a lot of Canadians have questions about medical assistance in dying, but they don't know where to start. They don't know where to begin. And I think it's very important that we understand what's happening, because, again, it's very important for us to be talking about it openly, because I don't know if the government really knows what they want as well from MAiD. It's a big medically ethical challenge that we have to explore. So in the latest report from Ontario's MAiD Death Review Committee, they focused on dementia. And what they found were a few things. So between 2023 to 2024, only 103 MAiD deaths were attributed primarily to dementia, which is about 1.1% of all MAiD deaths. So a very small fraction. The average age was 80 years old, and 60% were men. You might be surprised by the numbers and how small this is, but it's the complexity around these cases that are very important for us to know more about. because I'm certain many of us know friends and family who have dementia, and knowing this information is actually very important for them. So that gives you a snapshot of the types of MAiD deaths that the Death Review Committee was looking at. But here's where it gets interesting. 13% of all dementia patients who accessed MAiD received palliative care. Now, I want that to sink in a little bit. Now, I know there's only 100 deaths and they only account for 1.1% of all MAiD deaths, but 13% of dementia patients actually received palliative care. So that means 82% did not. And so now you think back to the 103 deaths of MAiD through because of primarily due to dementia. If all 103 patients had access to palliative care, would they have still chosen MAiD? Would they still have chosen MAiD when they know that palliative care is trying to provide as much comfort, as much care in the in those stages of life? And it's like palliative care can help alleviate the suffering. Now, I mentioned suffering for a very important reason, because suffering is something that we often think about when it comes to MAiD. We think someone is choosing MAiD because of the physical pain, the physical pain being too much. And what we actually see is that the physical pain isn't why people are selecting MAiD. This is what's interesting. 95% of all patients who had dementia who qualified for MAiD cited loss of dignity as the reason. 92% loss of independence, 87% feeling like a burden. These were the reasons why people were choosing MAiD, not because of a physical pain. So very interesting. Very interesting as well, the fear of institutionalization, the fear of caregiver burnout, the discrimination against disability. These are the reasons why so many choose MAiD, and not because of a physical physical pain being too much. This is fascinating to me, because often we hear the physical pain is too much, which is why people are selecting MAiD, and it's actually not the case at all. So I'm going to pause here for a second and say, if we understand that the loss of dignity is in fact a reason, the loss of independence is a reason, feeling like a burden is a reason, feeling socially isolated is a reason, fear of being institutionalized is a reason. If we understand all of these as reasons for choosing MAiD, could this not be solved, quote unquote, by providing the patient with enough wraparound services and care? Right? Like, so social isolation could be a reason. Okay, so why don't we engage in social therapy, talk therapy, focus groups, cognitive behavioral therapy, connection with spirituality, connecting with emotional intelligence courses. This can help with fears of institutionalization, the loss of independence, the feeling like a burden, right? If we helped the individual understand that there are going to be caregivers that will help you, and maybe individuals have the money, or maybe they have family that would be willing to support them through this. Would this reduce the number of patients saying that they're feeling like a burden, they're feeling like they don't have dignity? If we were able to do these things for the individual. And the reason I say all of this, folks, is because I'm not a big proponent of like therapy as an intervention to change your life, because really, therapy or talk therapy or social, all these types of therapies, they can only work if you change your behavior over a sustained period of time. So a lot of it has to do with yourself. Maybe someone can point you in the right direction, but really it has to come from a yearning within to say something's not right here, and I'm willing to work through it to figure this out. So it's not right sometimes for me to assume that, okay, well, if you just go to therapy, it's going to work. Like, that's a fair assumption to say, you know what, Christopher, that's not correct. But we do know that sustained exposure to many of these treatments does have a positive impact. We do know that. Like, there's a lot of evidence and a lot of research that shows that. And I remember reading something somewhere that said communities that are highly religious have extremely low levels of like anxiety, stress, depression. And ideas of suicidality, things like that. So very interesting that we can talk about the idea of therapy as a method to talk to dementia patients to potentially not choose MAiD. I want to then, and I want you to think about this as well, because this is very important. When it comes to medical assistance in dying, we don't want to talk about like the wraparound supports that do exist and that are out there. I think that's very important. It's something we shouldn't kind of gloss over. And I'll say this. Everybody goes through their things, right? Everybody goes through ups and downs. It's the valley, everything that happens in life, 100%. All of us go through it. But when we look at people who have really, how they've been able to cope, 9 times out of 10, they connected with something or someone. I mean, it's very ubiquitous for people to say that, it was religion that saved me. It was my friends and my caring family that saved me. It was, it was a social support network of some kind that really saved me. And when it comes to medical assistance in dying, I feel like we're not talking about that real impact that spirituality, religiosity, connecting to something that's bigger than yourself has on an individual. I think that's very important. I want to also mention that these reports talked about the timing and the assessment practices. So what's really interesting is that dementia patients typically waited longer for the provision of medical assistance in dying. 70% waited more than a month. And this is high because most patients wait, that length is usually only about 37% of patients wait that long. So MAiD is a very efficient system. As soon as you get assessed, it's very quick that you are put down, which is a terrible way of saying it, but it's true. Jay, thank you for the follow. I appreciate that. Folks, if you haven't already, hit that like button and subscribe. I sincerely appreciate that. And also check me out on YouTube under my full name, Christopher Balkerin. Hit that like button and subscribe. I think it's so important now more than ever. And I think it's very important that we have these open conversations online because we need to have them now with each other. So dementia patients wait approximately 70% more than a month from request to provision. But here's where it gets interesting, because the report also highlights where some individuals were assessed and provided MAiD in a single meeting. And in one case, someone was assessed for MAiD while going through an episode of delirium, which is really interesting. And so this has been something that honestly always comes up, is that people are being rushed into MAiD and they're being selected for MAiD under such wild circumstances. And I think that's very important that we talk about that, and we talk about that like as openly and honestly as possible. And so timing and assessment is very important. We also have to remember that people are saying that they feel like they're being rushed into selecting MAiD. And so, again, let's go back to the theory that someone has dementia. Now they have all these fears building up in their mind, and they're like, you know what, maybe MAiD is the best way for me. What we're also seeing in Ontario in particular is clinician burnout and clinician overload. So clinicians in Ontario are taking on a lot of MAiD cases. And it very well could be the argument that there are too many cases and clinicians may just be looking for the fastest way sometimes to get someone approved or, speed up the process. That's where this gets a bit awkward and weird. Like, if that's the case, then we should really be doing bigger audits of medical assistants in dying and making it even more regulatory burdensome to some degree. I know that sounds weird, but I just feel like when it comes to death, we have to be so restrictive, because this is state-sponsored death when you think about it. Okay. I also want to mention here that poverty, housing insecurity, and lack of home care are also cited as reasons for some selecting MAiD. Now, again, we can't solve poverty. We can't solve housing insecurity. We can't solve lack of home care, but a lot of these things are broader, right? We can't solve poverty and housing, but if the person had proper funds to support a comfortable home life and home care life, would they still select MAiD? And so if that's the case, what are some of the things we can do for lower income people or people who don't have the finances to do that, right? What are some of the programs? And let's not make this necessarily income tested, because it's the middle class as well that can very well fall into this category as well. Just because you're making $100,000 a year does not mean that you have $100,000 in the bank account. Just because you're making $150,000, $200,000 a year doesn't mean that you're necessarily good with, you're not good, but good's a relative term, but doesn't mean that maybe you've had to take care of elderly parents. Maybe you have younger children to take care of. Maybe you have other bills to take care of, and you don't have as much in the bank as you could. And perhaps at a certain stage in life, you were paycheck to paycheck, So all these things can factor into account when thinking about what the next steps are. And so poverty doesn't have to be like you're poor and living on the street. Poverty can be very well for those that are living in middle-class lifestyles and are struck with this health issue. And so what do we do for the middle class, say, who may have this diagnosis, and what supports can we provide in the short term? I think it's very important that we do that. Okay, the last thing I want to say before I end this, which I think it's a very important topic, is I think we have to, as Canadians, we have to talk about the reality that when it comes to medical assistance in dying, it is a grim topic. It's such a grim topic that I don't think our governments appreciate how diverse our perspectives are on MAiD. I think it's something that they actually thrive off us not talking about. So I encourage all of you to talk about MAiD and discuss it, and specifically Ontario's recent report. More reports as we enter the fall and winter are going to come up here in Ontario. I see that comment. I'd rather talk about MAiD than Wally. So I think it's important as we as Canadians talk about this, because I do think that our government really does basically they don't concern themselves when we're not talking about these things. So I want to encourage all of you to check it out and check out some of the reports. Dr. Ramona Coelho has also written about this in Macdonald-Laurier Institute. So definitely check that out. And I think the more we talk about this, the better. Anyway, so if you haven't already, subscribe. Christopher Balkrin right here on YouTube and TikTok. Like, share, comment. My first newsletter my revamped newsletter is now available. So if you haven't already, head to openminds.beehive.com. It's actually in the link in my YouTube. So if you subscribe to my YouTube, you'll see it in the links. Check that out. Get subscribed, and I'll definitely catch you in the next one. Thanks, everyone. Have a great rest of your day, and I'll catch you in the next.